Okay, so our lecture about skin disorder, pharmacology or treatment of skin disorder, we're going to focus on most of the lecture here the image is coming from the Google image. So sometimes I don't have reference in the image, but I have it here to disclose most of the presentation images coming from Google image. Other than that, I have the citation. Okay, so we are going to focus on three main topics. As you can see here, we have acne vulgaris, we have psoriasis, we have atopic dermatitis. So three main topics. And we have at the end, we have some other miscellaneous topics. It's not required for the exam. So what is required? This one, vulgaris, psoriasis, dermatitis, or eczema. For student activity, if you don't have 4 cases, this is another option for student activity to write a prescription for patients from eczema or any other skin disorders. So the skin disorder in general, as you can see, the major skin disorder we have could be infections, could be inflammation, could be cancer. So we have 3 main popular skin disorder: infection, inflammation, and cancers. Okay, back the infections, we talk about infections here. This one here, the main one, could be bacterial, could be fungal, or parasitic, or viruses. So this is a category. We don't discuss pharmacology here. So you can make it like reading only. We don't go in depth here. It's not our topic. This is our topic here, acne vulgaris. Okay, for acne vulgaris, it's very common cases. We know that. And we have, you can see here, we have for pathogenesis, we rely a lot on pathogenesis, pathophysiology. We need to understand pathogenesis, pathophysiology, because our medication work on these variables. So what we have here, they found the patients suffer from increased sebum. Okay, increase the hyperkeratinization. What happened else? We have infections with the Propionibacterium acne. So this is number 3, and last one will be inflammation. General approach here, normally we use a combination therapy, and combination therapy found is like more effective. And when you use combination therapy, this will decrease side effect because you minimize the resistance and tolerance. And this explains why you use combination therapy. Topical therapy is very important also to maybe remember that when you have mild, moderate case, we will go with the topical therapy. No need to use anything oral or injection. So, okay, when you have mild or moderate acne, so we go with the topical treatment. When you have moderate to severe, we go the oral or injection systemic treatment. So we have 2 main approach: mild, moderate, go with the local; moderate to severe, we start with the systemic. Okay, you have the patients from acne. What is the purpose of treatment? So what is the goal of therapy? Number 1, to lower, you can see most of these like lower. So if talk about here, decrease most of these option here. So you can see here, lower sebum production, lower hyperkeratinization, prevent bacterial growth, decrease inflammation. All these like decrease, as you can see here. Okay, decrease sebum, decrease hyperkeratinization, prevent bacterial growth, and decrease inflammation. Any question about the goal of therapy? We have a question about the goal of therapy in the exam. So what is the goal of therapy of acne vulgaris? Okay, this graph, I like the table for when you have it there. For example, we can use salicylic acid. We can use it like topical retinoid or topical antibacterial. Sometimes we inject corticosteroids. So you can see here, we have corticosteroid in several topics. Hormone therapy, yes, for the acne, could be oral contraceptive. We can sometimes we use Spironolactone, and we have another medication, consider like a new medication in the market, and the brand name Monlevy, and the generic name Clascoterone, cream 1%, oral cortisone sometimes. But remember here, when you use cortisone for acne, they said they recommend us to use high dose or short course. So we use it only for short term, not for long term. So the ideal treatment, first drug treatment, is not cortisone. Acne is not first line treatment. But if you remember with the acne, if you remember in the beginning, we have inflammation. And they said cortisone, it decreases inflammation. So we can use it to decrease inflammation, not to treat acne or cure acne. Oral, this is important. What oral medication available for acne? Isotretinoin, doxycycline. You are familiar with this name, is that correct? And then we have erythromycin, monocycline. This is the most popular oral. Any question about this list here? So we're going to discuss it in details in next coming slide. Okay, the first medication about the acne, we need to remember why we use this medication and in what stage is like appropriate. The first medication, benzoyl peroxide, and as you can see here, we have it like a solution, or it could be cream or gel, for example, here. So we have it all the maybe pharmaceutical form available. Benzoyl peroxide, first-line treatment for mild to moderate acne. No need for prescription. So it's available OTC, over the counter. So the patient can go to the supermarket and buy this medication called benzoyl peroxide. First-line treatment for mild cases, mild, moderate. How benzoyl peroxide work? We have three maybe mechanisms. You can see it here. Bactericidal, able to suppress the bacterial, perobionic bacteria. Mild chemidolytic, suppress sebum production. So three main effects, very similar to the retinoids. Okay. Nothing to add about benzoyl peroxide, mild to moderate. We have the bactericide, chemidolytic, suppress sebum production. Any question about benzoyl peroxide? Okay, so first of all, we need to remember the application, mild to moderate. Number two, for this slide, we need to remember how this medication works. Okay, this is maybe two main target for us. Azelaic acid, we have it as cream and gel. Okay, again, for mild, moderate acne. How this medication work? You can see here, if you go to the benzoyl peroxide, there's no effect on inflammation. But azelaic acid, we can add the first three the same, and this is new. Which one here? This one, the new anti-inflammatory activity. So the same as benzoic acid, but we add anti-inflammatory effect. So azelaic acid work as bacterial, antibacterial, anti-inflammatory, inhibit keratinocyte, chemidolytic effect. We have some side effects here. You can read it by your own time. Irritation, burning, stinging, and so on. Any question about this three medication, the first two medication, benzoic acid, azelaic acid? Did you cover that in the clinical medicine? Okay. Moving to the next question here, salicylic acid. So the third medication, salicylic acid, we use it for as exfoliants to clear comedonies. Okay, they said this medication used for patient cannot tolerate retinoids. So I will go back. If you remember the first two medication, we use the first two medication for mild, moderate. Does that make sense? What about this medication here? We use it for patient cannot tolerate retinoid, topical retinoids. This is the alternative here. Salicylic acid, we use it as keratinolytic effect, anti-inflammatory effect, chemidolytic effect. What is missing here? We miss one mechanism of action here. Is that correct? Can you remember which one is like missing? It's not like belong to the salicylic acid.
Antibacterial.
Correct. So salicylic acid has no antibacterial effect. Please remember that. If you go to the azelaic acid, we have antibacterial effect. Okay, back to the salicylic acid, we don't have antibacterial effect. Important issue for the practice, for example, here, you can go to the supermarket or like to the mall and buy the medication over the counter with the concentration 0.5, 2%. But if you need more strong salicylic acid, for example, 5 to 10%, this needs prescription. Does that make sense for us? So when you use like 0.5 or 2% over the counter available, but if you need like stronger medication, high concentration, prescription needed. So we need to remember that concentration. Over the counter, 0.5 to 2%, but prescription 5 to 10%. Again, we have some side effect, like we don't have any highlight important things for us. Okay, three medication now or repeated. benzoic acid, benzoyl peroxide, azelaic acid, salicylic acid, 3 medication. Okay, this is the like introduction to the acne. Then we have Dapsone, Axon. Okay, Dapsone, Axon. What happened there? They said this medication antibacterial, anti-inflammatory properties, useful in patients with the sensitivity or intolerance to the conventional anti-acne drugs. So Dapsone is not main medication, but could be used. Now we have gel 5%, and I've seen, I learned from the dermatologist, we have 7.5%, and this need prescription. So this is available, Dapsone here, but this one also available. And I've watched YouTube for like 17 minutes about Dapsone. I like the YouTube and coming from dermatologists speak about this concentration for the acne. And Dapsone could be combined with the Adapalene or benzoyl peroxide. And you can see it in one on the same cream, like combination therapy. Okay, so I think you don't have this slide. I'm going to make this PowerPoint available for you because we have a question about that. For Dapsone, we know that has antibacterial and anti-inflammatory actions or properties used for patient intolerance to the anti-acne agents like retinoid or other medication. Okay, they said we need to be careful about, we have forewarning, we have something called methemoglobinemia. Important one here, so we have some patients suffer from G6PD deficiency. And they warn us about if the patients are from just this case of genetic deficiency, not allowed to prescribe Dapsone to the patient, even with the local effect. Okay, a glucose 6-phosphate dehydrogenase deficiency. So Dapsone, one of this medication. So we can ask a question: with the following medication, topical medication, is not allowed to prescribe to the patients suffer from G6PD. Does that make sense? Okay, this is a question here. And if you click on this one screenshot, I got it from the drug prescription. If you click on the link here, they will take you to the full drug prescription, and you can read the information about Dapsone. So how many medications so far? So, okay, the first one, benzoyl peroxide. The second one, azelaic acid. The third one, salicylic acid. And number 4, Dapsone. Okay. Now we start to speak about the most important group of medication. And I update this one. I added this one here. It's not on your slide. You can add it, and I'm going to make it available for you. I'm still working, update my slide until last minute before I meet with you. So I'd like to bring you maybe the best slide. Retinoid, group of retinoid, we have less of medication belong to the retinoid products. Adapalene, for example, we have Isotretinoin, we have Tazarotene. This is not on your slide. You can add it, please. Tazarotene, and we have Tretinoin, we have Trifarotene, and what we need to remember here. So list of medication. We need to remember this list of medication. What else? You can see here available cream, gel, lotion, and ointment, for example. It's very important to remember we have 4 generations. First generation, second, third, and fourth generation. Some textbook put the Trifarotene in the third medication, some textbook. So we need to remember this category here. Okay. So the first generation, we have retinoid, tretinoin, and isotretinoin. First generation. Second generation, we have acitretine. Second generation. The third generation, we have Adapalene, then we have Tazarotene, and then we have Pimecrolimus. Then generation number 4, we have Trifarotene. So the question, we use it only for acne. Retinoid, they said we can use it for acne. We can use it for wrinkle, psoriasis, warts, dark spot, Kaposi sarcoma, melasmas, and stretch marks. When I read the stretch mark here, I remember cortisone. Cortisone cause or treat stretch marks. What do you think? Cortisone causes or treats stretch marks? So here we talk about retinoid, but you remember we already covered the cortisone with you. So when you have a cortisone cream, do you think it's a good idea to prescribe it? Pause, Denise. Thank you. So remember here, if you would like to remember the answer for this question, remember Cushing syndrome. Cushing syndrome, we have stretch marks on the skin. So it's not allowed to prescribe cortisone to the patients of from stretch mark. But can we use something? Yes, they said retinoid will be possible, maybe solution for the patient. Please remember all these possible maybe treatment, possible clinical use for retinoids. Okay. This medication, I brought this medication here because we have it in the market. You can see it here, the brand name Acleaf, and it's coming like a cream here. And the generic name, the Triforotene, and the concentration 0.005 cream. And this medication could be applied for anyone about age 9 and above, 9 years old. Okay, fourth generation retinoids, Acleaf. So the question in the exam or in the national exam, which of the following retinoid belong to the fourth generation retinoid, for example? We have triparotene. Which of these medication could be prescribed to the for children above 9 years old? We have the triparotene. Okay, all the retinoid medication, all the retinoid is not allowed to use pregnancy. Avoid during pregnancy. Please remember that. We don't prescribe isotretinoin during pregnancy, even a cream or ointment or something. We don't recommend to use it during pregnancy. And the reason, because I would like to verify the information, as I told you, in some textbook be classify trifarotene as third, but this is coming from the textbook here. You can see it here. Topical trifarotene Acleaf is the first in a class, fourth generation. You see it here. So fourth generation, not the. Okay, how this medication work? This medication work as selective retinoic receptor gamma agonist. Okay, and we have the pharmaceutical company and so on. Another question, we need the student to remember the category. You can see here we ask about category. Which one is third generation retinoids? So most of the students agree with the D and E, Adapalene and Tazarotene. Does that make sense? So this maybe you consider like easy question. Maybe depends on the memories. We need to remember the medication here. Okay, important, very important slide. Very important slide about retinoid. When you prescribe retinoid or retinoid. So what we have here, patient may suffer from irritation, dryness, skin peeling. Okay, 40% of patients suffer from this side effect. Very popular. Photosensitivity, yes. When you prescribe this medication to your patient, and you need to warn the patient to wear sunscreen because this medication causes photosensitivity. Give me another medication may cause photosensitivity. I will maybe ask in another way. Doxycycline, nice, Lauren. So doxycycline, tetracycline may cause photosensitivity. That's great. Thank you so much. Again, moving to the next one, dry mucous membrane, 40%. So therefore we use some cream to maybe like some to moisturize the skin and prevent the dryness of the mucus. Hypertriglyceridemia, lower HDL. So triglyceridemia will be lower. What do you think? Lower or higher? Higher triglyceridemia. Hypertriglyceridemia type of cholesterol will be high, increased. Hepatotoxicity, and the patient suffer from elevated liver function. Suicidal ideation, suicidal attempt, all these coming from retinoid. This medication considered like teratogenic. Therefore, it's absolutely contraindicated during pregnancy. It's not allowed to use it in pregnant women because of the teratogenic effect. And we call this one PPW, black box warning. Okay, so we are going to have another slide, then we come back if you need to read more information about that. So any question about this adverse effect? And I will call this one adverse effect, a precaution, warning. So all these apply on the table. So we need to be careful about irritation, photosensitivity, maybe give the patient information to wear sunscreen, uh, with the hepatotoxicity, lipid, all these we need to be taken into consideration with a retinoid. Okay, black box warning is very important here for isotretinoin. Here we talk about oral. You agree with this one? And you gave me the name, the brand name Accutane. Okay, do not use this medication in female who are or may become pregnant. What do you think? Yes or no? You agree with this one? Okay, do not prescribe it. It's very important. Or because of the high risk. Thank you so much. Because of the high risk of teratogenicity. Okay, thank you. What happened if for example, you prescribe to someone and the patient become pregnant? They said stop the medication immediately. So we need to stop the medication immediately if the patient become pregnant here, and we need to refer the patient to the OB/GYN clinic. So this is another option here. The third one here, they said the medication in some patient. So here we're talking about percentage, suffer from depression, psychosis, and patient may suffer from suicidal thoughts. So you can see here the warning from the isotretinoin, pregnancy and suicidal thoughts, very important main concern for the healthcare provider. And you need to maybe educate your patient about these two main things: pregnancy, not allow, contraindication, absolute contraindication. Then we have suicidal ideation. Okay, so how we can monitor your patient here? Necessary laboratory tests. Okay, we need to do a pregnancy test. They said we need to have like two negative pregnancy tests before 2 weeks before the treatment. Two pregnancy tests, not one. Then number two, we need to ask about liver function test. So we use this one because this medication causes hepatotoxicity. Okay, number three, this medication increased triglycerides. We need to ask about fast lipid profile. So three things need to be monitored for this patient. Number one, liver function. Number two, pregnancy test. And number three, lipid profile. Does that make sense for the isotretinoin? So before you prescribe it and you monitor your patient, you prescribe isotretinoin, everything negative now, everything negative here. But when you put the patient on that treatment, you need to monitor the patient for the liver function and lipid. That's fine. 1, 2. What about the pregnancy? For the pregnancy test, it requires something called eye pledge. I believe we have it somewhere. Here, let me look on the. It should be here somewhere. Eye pledge. Accutane. Yes. So we have it there, and patients maybe give the information leaflet, carry the card with them for eye pledge, not to use any or not to try to get pregnant during this treatment. We have some information there, and this is student activity. If you like to bring us some information and maybe upload it to this, send email to me with the upload to the canvas about eye pledge information. Okay, so three things need to be monitored during treatment with. Thank you, Jenny. Okay, so liver function, pregnancy test, and triglycerides. So the question, which type of lipid need to be monitored during pregnancy, during treatment with the isotretinoin? Triglyceride. Thank you, Denise. So because we have triglyceride, we have cholesterol, we have fatty acid. Okay, so all these lipid. So, but triglyceride need to be monitored there. So another question about triglyceride. What is the normal value for triglyceride when you do lipid profile? What is the normal value for triglyceride? $150. Nathan, thank you. Okay. Okay. What happened if you see maybe I have seen patient with a 500 and another patient 1200 milligram per deci triglyceride, and the risk from that, we call this one hypertriglyceridemia, familiar hypertriglyceridemia. and the patient may die from pancreatitis, acute pancreatitis. Increased level of triglycerides, high level of triglyceride may cause pancreatitis. Nice, Denise, prescribe fenofibrate. Okay, I don't like to switch my lecture to the lipid now. Lipid is not coming in the spring. You are going to see it soon. We have 3 hour teaching about hyperlipidemia, so I'm not going to spend the time about speak. But lipid is very important, as you can see here. Triglycerides very important. Topics similar with the cholesterol, LDL, HDL. Please remember from this slide here, 3 things need to be monitored during treatment with the isotretinoin. Okay, we're done with the maybe in next group of medication. Can you summarize what we have here? I will maybe someone start with the first medication. What is the first medication was? Okay, we discussed as written. We discussed that. We maybe spend some time about retinoid and isotretinoin and the medication name, the precaution, the side effects. Very important for us to mention maybe monitor that. Moving to that, maybe next group we have antibiotic. We use antibiotic because we have bacterial. We have Propionibacterium acne. So the most popular one we can use it like topical or oral. Here we need to remember we have topical and oral. With the oral, we are familiar with the monocycline, doxycycline, and this belongs to the tetracycline. Then we have erythromycin. So this is oral, and we use it for moderate to severe acne. Okay, what about topical here? Preferred treatment. Always we prefer local more than systemic. Okay, and you can see it here. We have clindamycin, for example, and we have erythromycin. Clindamycin and erythromycin, topical. Okay, could be cream, could be gel, could be. So we have it in several antibiotic. At the main purpose here to treat or eradicate the bacteria. Does that make sense? So what is the main purpose? To eradicate the bacteria, because we have infections component on the acne. Okay. Hormonal agent. So you can see with the antibiotic, we have only one slide. We don't go in depth because during the spring we have infectious disease. You are going to see me in 2 lectures there, 6 hour or 5 hour teaching. And on the YouTube, I have 11 YouTubes about antibacterial and details about bacterial. So we don't spend time about what is erythromycin, what is clindamycin, how this medication work. For the purpose of dermatology, we need to remember which antibiotic we use it for acne. But when you speak about ID, infectious disease, we go in depth there. Okay. Okay, hormonal agents. Here we spend maybe sometimes here. Oral contraceptive, they found, okay, the oral contraceptive, here we talk about estrogen therapy. And they found estrogen therapy could be useful for a treatment of acne. And because estrogen has some anti-androgenic androgen effect, anti-androgen effect. So if you remember, if you go back, the androgen will be a increased level, maybe possibility of acne, and this estrogen has anti-androgenic activities. Okay, if you can see here, the FDA approved acne, approved treatment for acne for like who desire to FDA agent approval acne in women who also desire contraceptive. So this is in this case, for example, if we have some women suffer from acne and at the same time willing to use a contraceptive, that's great. We have 2 purposes here: to prevent pregnancy and to treat acne. What we have here in the practice, we have norgestimate ethinyl estradiol. Wow, it's very difficult to remember this name. Norgestimate ethinyl estradiol. I think it's ethinyl or ethinyl estradiol is popular name, estradiol. And if you like to remember estradiol, what is this? EST, we have ES, we have estrogen. You see the first 3 letter here, estradiol, estrogen. This is estrogen. I like it. That's fine. What about norgestimate? Norgestimate, consider, if you look what we have, just this belongs to the progesterone. So kind of combination between progesterone and estrogen. But we have specific hormone, norgestimate ethinyl estradiol. Okay, we have another one also for the acne. We have this one called the trisprintic. We have another one, northindrone, with that same medication, ethylene estradiol. So we have two medication belong to the hormone agent therapy, contraceptive, two contraceptive used for contraceptive and acne. And if you like, I put it here as a category, as a reminder for you. It's not required, but reminder. What is norgestimate, progestin, northindrone, progestin? If you like to remember which one, we have the first three letter, ethinyl estradiol, est stands for estrogen. So this one, hormonal agent. Okay, any question about the hormonal agent or contraceptive, oral contraceptive? What else here? We have spironolactone. I remember I gave the spironolactone to some student as drug fact to upload on student activity. As you can see here, spironolactone has anti-androgenic effect. So we have anti-androgenic effect, spironolactone. What else? Any idea what is spironolactone used for what, or what is the mechanism of action? How this medication work? Spironolactone. Have you heard about this medication before? Can you help me with the reminder of category of this medication? Spironolactone. What is spironolactone? If someone asks you about this one during your clinical rotation in the internal medicine, hormones, destiny, diuretic, nice, two things. HTN, used for hypertension, diuretic. How this medication work? What is a category? For example, when you say nice, Ayana, thank you. And you see in the chat box, we have it there, aldosterone antagonist, and we have anti-androgen. So remember all these data here. Aldosterone antagonist. And we discussed that with you when we spoke about cortisone. You remember cortisone? And with the cortisone, we discussed the aldosterone. Do you like some refreshment about that or no need? It's totally up to you. Okay. No comment? Okay. So what we have, again, this is a refreshment because we have 10 questions for the cortisone or glucocorticoids. Okay, what we have here, the issue here, I have the keyboard in front of me and I couldn't move. Let me remove that keyboard. Type something on the screen. For corticosteroids, you remember that we have two main groups. We have mineral, then we have gluco. You remember that? Okay, for the mineral, when you speak about mineral, so here the main hormone here will be aldosterone. When you speak about the glucocorticoids, the main hormone here will be cortisone or cortisol. This is inactive, and this is active. Another name for the cortisol, another name. Give me another name for the cortisol. So cortisone and this is the same name. Cortisol and hydrocortisone, the same name, active medication. Okay, so aldosterone, you can see here aldosterone. We have binding, this medication work by binding to the receptor. So you can see here we have aldosterone bind to the receptor. So our medication, spironolactone, I don't know what happened here. Okay. Spironolactone inhibit bind to the receptor and inhibit the receptor. Consider like aldosterone antagonist. So aldosterone antagonist, you remember that. So we need to type here a word, a very important word, antagonist. I've seen that in the exam. Some students struggle with the agonist, antagonist. That mean when they say antagonist, might mean bind to the receptor and block the receptor. Okay, we can go for a break. Give me 1 second and to finish this one. Then we go for finish the hormones. So the first one, the second one for the hormone, the first one was contraceptive, oral contraceptive. And the second one will be spironolactone. We use it for acne because of anti-androgenic effect. Then they said, okay, you said that anti-androgen medication we use for acne. And the pharmaceutical company start thinking about developing a medication work on the androgen receptor inhibitor. So this medication, selective medication, inhibit the androgen receptor, and they developed the cream called Clascoterone. Clascoterone is like Winlevi, the cream, and androgen receptor inhibitor. And this medication used for male and female patient 12 years and older. So this medication for acne at the age of 12 and above. Okay, I don't know what happened. The music stopped suddenly. Okay, so it's 9:50. So let me finish the last one here and we move to the break. So Clascoterone, cream, Winlevi, and consider like androgen receptor inhibitor. The question from the slide here, okay, which of the following medication used to treat acne by inhibit androgen receptor? So remember, Winlevi or Clascoterone. Okay, which of these medication inhibit androgen receptor and use in male and female above age of 12 years? We have Clascoterone. I'm giving you the question. No excuse in the exam to miss the question. Does that make sense? This is a question and only practice. Okay, moving to the oral corticosteroids. Okay, very important issue. We don't use cortisone for acne. But you know that when you have severe acne, look what we have here. We have inflammation. You agree with this one? We use it for short term and high dose only to relieve inflammation. Does that make sense? So the purpose of cortisone in acne, in severe acne only, we don't use it in mild, moderate. So we are going to put it in the possible answer. For example, which of these medication used for mild, moderate acne? I'm going to put cortisone there. It's not supposed to select cortisone. Cortisone only for severe acne to relieve inflammation. It's a very important issue here. So please remember these the keyword for cortisone, severe acne to reduce inflammation. We use oral cortisone. Okay, any question? Okay. I will stop here for 10 minutes, then come back for our lecture. See you soon. Okay, hello everyone. Can you hear me? We done with the acne, and this one for reading only. And what is the purpose from this slide? This is the guidelines. So when you attend dermatology clinic, okay, so we have the patient come to the clinic suffer from, depends on the type and severity. If you have mild, moderate, we have severe acne. Okay, when you have like mild topical retinoid, and we can go the retinoid. If you have it like severe cases, we go with the oral isotretinoin, depends on the approach. Keep it reading, but remember to prepare yourself when you go to the dermatology clinic for clinical rotation, reading the guidelines, familiarize yourself with the medication name, pharmaceutical form, and the potency, for example, for the medication. Another one here coming from the maybe guidelines, Canadian guidelines, they have different, for the acne vulgaris, you can see here they have different approach for the treatment here. Okay, so what we have here, severe acne, oral isotretinoin. So again, we can read your information, and this one should be applied for your clinical rotation. Okay. Okay, we're done with the acne, and we discuss and we cover all the information regarding the most popular information, not all the information, because we have a huge amount of information about acne. We cover the general major guidelines for acne. Any question about acne before we move to the next topic? Okay, so as stated in your syllabi or syllabus for the dermatology, maybe 625, we need to cover three area: acne, psoriasis, and eczema. So three topics, and we have some maybe miscellaneous topics. I will leave it at the end for your references and reading, but it's not required for the exam. I'm not sure what happened here. I'm covering my camera there, just in case I make it open. So psoriasis, they start talking about prevalence of psoriasis, like 1 to 2% of population, how this psoriasis maybe appear, erythematous and black epidermal hyperproliferation. The causes could be genetic, the causes could be autoimmune disease. So the approach for the psoriasis is totally different from the acne, not the same treatment, but we have some medication could be used. For example, for me, I will remember Tazarotene, and we have another medication called Acetretine. Acetretine and Tazarotene coming from the acne. We use it for psoriasis. Please remember, two medication used for both acne and psoriasis. Okay, so we have two cases here. Again, when you have mild, goes topical. When you have severe, goes systemic. Does that make sense for us? Okay, move to the next. Thank you, Koina. So moving here, this slide here, again, to familiarize ourselves with the types of psoriasis. Could be eruptive, could be vulgaris, could be arthritis. So we have several types, and our type here, this is a clinical medicine. This is diagnostic. The classify category of psoriasis. It's not my topic here, but we need to be familiar with the clinical medicine diagnostic or clinical rotation is required from you to be familiar with this one information. I brought this one to know, okay, we have different type of psoriasis, severity, maybe category, distribution. So many criteria should be taken in consideration when you approach patients from psoriasis. Okay, now start talking about treatment. We start again. This reminds me with the allergic rhinitis. We have topical for allergic rhinitis. We have systemic for allergic rhinitis. The same apply here. We have topical for psoriasis. Then we have systemic. What we can use for topical? Number one, cortisone, topical corticosteroids, and two medication: betamethasone, hydrocortisone acetate. So we're going to, in this lecture today, we're going to learn about cortisone for the skin. We have different category. We have 7 category for corticosteroids. 7 category. We need to remember these categories. Then we have calcipotriene and Defonex for the treatment, and this one derived from vitamin D. Calcipotriene, the vitamin D. If you like to remember this one here, vitamin D, you remember vitamin D with the close relation with the calcium. Is that correct? Vitamin D, increased level of calcium in the blood. So can you look what we have the first two letter here? Calcipotriene, Ca. So which of the following medication derived from vitamin D? I'm going to bring a list of medication. No need to miss this question. Calcipotriene. Does that make sense? So this one may give us some clue how to select the answer if you don't know anything about the medication. So you can see vitamin D, increased calcium, calcipotriene start with the Ca. Tazarotene, and this one belong to the which group of medication? Tazarotene, Tazorac. Did we discuss it in the today? Belong to which medication? Okay, third generation, the retinoid. Okay, great. So please remember this one, third generation retinoid in the chat. Okay, then we have tacrolimus, then we have Pimecrolimus, all these cream here. Okay, two medication belong to the cream. Salicylic acid, we have some overlap between acne and psoriasis. Then we have coal tar, then we have Anthralin. So this medication considered like topical medication. But remember, the first medication, cortisone. The second medication will be calcipotriene. We are going to discuss it later on. So for psoriasis, number one, cortisone. Okay. Topical corticosteroids, primary initial therapy for psoriasis. It's very important things. Primary initial therapy. The first medication for the psoriasis will be topical cortisone. Effective medication, inexpensive and safe because you don't apply it on the skin topically. It's not oral, not injection. Two medication available for in the practice. We have betamethasone, Dapsone, available ointment, cream, and lotion. Betamethasone. Then we have hydrocortisone. Okay, Court Aid, hydrocortisone, available cream and ointment. Someone may ask why you use topical cortisone. They said because the skin suffer from inflammation, and cortisone reduce inflammation. You see it here, the main purpose here. They try to remind us with two things. We have category for cortisone. We are going to bring it later on. We have mild, moderate, and high potency. They said if you apply high potency cortisone, you can see it here. High potency cortisone, okay, it's best applied for the skin area with the thickest skin. So when you have areas like thick skin, like your palm or your feet, this is the best medication. Go with the high potency cortisone. Okay, but this high potency should not be used on the face or genital area. Does that make sense? So it's very important when you prescribe it to your patient. Is it on the hand or the feet or genital area or some other places? You need to select the cortisone appropriate to the patient. Okay, so the very important maybe points should be taken in consideration when you prescribe cortisone to the patient with a like allergic rhinitis or like dermatitis or something else or psoriasis. Any question about this information here about the slide? Okay, what is the main purpose of using cortisone in psoriasis? Reduce inflammation. Yeah. Thank you. Two most popular medication, we have betamethasone, hydrocortisone. We need to remember that. And the reason, an effective medication and expensive and safe medication. Salicylic acid, we use this medication because considered like keratolytic properties, try to peel the skins, enhancement. Okay, another important issue here, we normally use it combination with betamethasone. And the reason, and they said when you use it with the cortisone, salicylic acid enhance penetration of cortisone, allow cortisone to enter the skin, the epidermis, the dermis. Okay, so increasing the purpose to increase efficacy of cortisone. So the question now, what is the main purpose of using salicylic acid with the cortisone when treat patient with the psoriasis? To enhance activity of cortisone, enhance penetration of cortisone. Okay, salicylic acid. Okay, again, this is a local. This is local application. Salicylic acid, we apply it like local, could be could be lotion, could be cream, but they said you have to be careful. If the patient apply to the skin surface more than 20% of body surface area, BSA, more than 20%, what do you think here? They said there's a risk of systemic absorption. This medication will arrive to the blood. There is a risk of toxicity. You agree with this one? We are going to have large amount of salicylic acid arrive to the blood. And someone maybe cover Ray's syndrome before from aspirin. So for example, we can link the information here. Okay. Salicylic acid should not be used in children. We discussed that. We have the explanation for Ray's syndrome, for example. And limited, it may be used during pregnancy, which should be limited, and we don't recommend to use it, but could be used. This one we need to evaluate. For example, here we can evaluate, but if you speak about retinoid, absolute contraindication. So here we need to remember that. And another issue here, we can speak about aspirin. And I read one article about using aspirin during pregnancy to prevent preeclampsia. Have you heard about preeclampsia? Queen, what is, not for Queen, only for everyone. Try to Google it and tell me what is preeclampsia. Type it or say it. I am open for both. Okay, serious blood pressure condition developed during pregnancy, especially the third trimester. So the third trimester, the pregnant woman may suffer from hypertension. Okay, it's not enough to say to maybe call this one preeclampsia. We have three main criteria. Number one, hypertension. Number two, proteinuria, and number three, edema. So three characteristic for preeclampsia. I will repeat it: hypertension, edema, and what else? What is the third one?
Protein in the urine.
Thank you, Ejani. Protein, hyper or like proteinuria. So they found using aspirin may prevent from preeclampsia. So we can use aspirin during pregnancy for some studies. Does that make sense? So if you have pregnant woman come to the clinic, he has a history or she has a history of preeclampsia. So we can try and we, according to the literature review, okay, have a meeting with the pregnant woman, have a discussion, bring this article to the light, and we can prescribe it. And we have maybe a lot of article about this issue here. So it's not like contraindication during pregnancy. We can use it during pregnancy if you talk about aspirin. So it's not like X or D during pregnancy, but retinoid is totally contraindicated. Any question about salicylic acid? Okay. Coal tar here, this medication considered like keratolytic, anti-proliferative, and anti-inflammatory effect. Infrequently used for the psoriasis, not popular. Some patients will use it because like cheap medication. Patient unable to adhere to the treatment. We have some drawback for this medication. This medication considered like slow onset of action, unpleasant odor, and make some stains on the clothes. This may be some issue here. This medication may cause folliculitis. This medication may cause acne, irritate the skin, and phototoxicity. So it's not popular in the clinical use. Not first choice according to the guidelines, not in the first choice for the guideline. What is the first choice for the psoriasis? You are muted, Denise.
I was saying betamethasone.
Okay, betamethasone or topical corticosteroid. So, coal tar is like we can use it, but we have limited efficacy, and patient maybe does not adhere and accept this medication. Okay. Phototherapy and photochemotherapy. Phototherapy, we have UVA and UVB for ultraviolet treatment. They said we have photochemotherapy, then we add chemotherapy to the phototherapy. So for what type? We can add coal tar and we can add anthralene. That's fine. So it's not our topic. This like applicable. It's not more than specialist, and normally UVA given with the photosensitizer. and the photosensitizer called oral Psoriolane. And the purpose here to enhance efficacy. Now we have two medications to enhance efficacy. We use the Salicylic Acid to enhance efficacy of cortisone. Is that correct? You remember that? And now we have oral Psoriolane. We use it to enhance efficacy of UVA. So we have two medication enhance efficacy, other medication. Please remember that. They try to remind us with the patient treated with the BUVA, we need to provide the patient with eye protection for at least 24 hours. Okay, you can read the adverse reaction, nausea, vomiting, arrhythmia, and so on at your own time. So phototherapy, photochemotherapy, we need to remember UVA, UVB, cool tar, anthralin, oral Psoriolane, and we need to provide eye protection. So the question now, which of the following psoriatic treatment need to provide eye protection? So we are going to bring less of medication, and one of them will be BUVA. You see BUVA here? BUVA, okay, salicylic acid, cortisone. Which one we need to provide eye protection? If you take notes, you answer the question. Does that make sense? Okay, moving to the next one. Okay, so we're done with that. You remember the first slide was local topical treatment, and we discussed cortisone, cool tar, and Tazarotene. Okay, so what we have here, before we go back, we can use biological agents. And you are expert now with the biological agent. We have tumor necrosis inhibitor, with such as Humira, adalimumab, Remicade, Cimzia, all these TNF-alpha. We need you to remember 100% this medication, adalimumab, and the brand name Humira, and the list will be below. Okay, which one? Interleukin 17A inhibitor, secukinumab, Cosentyx, and I remember this name from the TV maybe advertisement. I've seen it a lot. For example, I've seen Taltz, a lot of this TV. You can type it, Google it, find it. Skyrizi now is on the TV several times, Skyrizi. And we need to remember which of these medications inhibit interleukin 17. Okay, which of these medications maybe inhibit interleukin 23? Okay, we're done with the biological. So we can use biological. You can see it here. Biological treatment on the table for the patients from psoriasis. On the table, not first choice. Okay. Again, severe. We use it for severe psoriasis, number one. For patient with a failed response to the topical treatment. This is another case. What we have here for psoriasis. Okay, have you heard about methotrexate? Yes, it's repeated. Rheumatoid arthritis. We have it here, methotrexate. Acitretin, Soriatane, cyclosporine. Can someone remind me what is cyclosporine? And anything about cyclosporine? Bind to cytoplasmic protein. More information. Okay, I will leave it to the next slide. I don't like to maybe distract you here. So we have methotrexate, acitretin, and then we have cyclosporine, tofacitinib. When you have citinib, most of the medication, oral anti-cancer drug now is like coming from citinib. We have a list of medication. Apremilast, then we have biological factor. We are going to discuss most popular medication from this list here, like briefly. We don't go in depth. Okay. Systemic therapy. Okay, you are familiar with the methotrexate. Most frequently prescribed. Cheap medication, effective medication. Acitretin, Soriatane, oral medication, Acitretin. You see it here. We will have it in like several, maybe 25, 10, 17 and a half. So acitretin, what is acitretin? Belong to which group? Retinoid? You agree with the retinoid? Which generation?
First.
First generation? Can you check for me, please? Acitretin belong to which generation? Third? Second? Oh my goodness, I like the answer now. Several students, several answer. One, second, first. Can you check and tell me the correct answer? Lauren, second generation? I will go with the majority of students. Okay, Joy, second generation. I've seen Denise say it yes. Denise, you say yes for the second? For the second? Okay, good. So second generation. Quina, second generation. Okay. What about cyclosporine? Cyclosporine immunosuppressant. We use for severe, and then we have biological factor or biological agent there. Okay. Any question about this one? We don't go in depth because we covered this all this information already, and we are going to bring one slide about acitretin with you to discuss it, and all these like methotrexate, biological agent, all these covered somewhere else. This is a very important slide, and I can create 7 questions from this slide here. First, for example, this is category for topical corticosteroid potency. We have, if you look on number one will be super potent. Please remember the category here. Number 7 will be the least potent. Does that make sense? So 1, the most powerful, the 7, the least powerful. So again, we have several issues here. The cream is more potent than, the ointment here is more potent than cream. We need to remember that, pharmaceutical form. Ointment is more potent than cream. This is number 1. Okay, so I will start with the class number 1, the super potent, not potent, super potent, number 1. Okay, we have betamethasone dipropionate ointment. Okay, 0.05. Okay, then what is the next medication? Clobetasol. Okay, yeah, clobetasol propionate ointment cream. The only one, it's not repeated. The only place here for clobetasol. So 2 medication considered like super potent. Betamethasone dipropionate ointment, and then we have clobetasol. Okay, if you look on the categories, class number 2, we have betamethasone dipropionate, but that's the cream. So the ointment most potent than the cream. Okay, flavonoids, that's fine. Moving to the class number 3, triamcinolone. And you are familiar with this name, triamcinolone. We discussed it somewhere else. And we have bemetazone, a cream ointment. We have bemetazone. You can see here we have ointment, strong. Cream is like the same medication. It's like less potent. Okay, how can I remember? Okay, which medication considered like least potent? What do you think? Hydrocortisone. Hydrocortisone 0.5, 1, 2, 2.5. In general, hydrocortisone, the least potent. Do you think hydrocortisone is available without prescription in the market? You can buy hydrocortisone. Kawina, Lauren, you can buy hydrocortisone. It's available in the market. You can go and buy like for maybe it's not expensive medication. And not cancer, because you said yes. Can you tell me what is the main indication for that for hydrocortisone in the market? They put it on the package there. Used for what? Hydrocortisone cream or like ointment. What is the purpose of selling this medication in the
Reduce
market?
inflammation,
Say it again. I mean the clinical use, most popular clinical use.
eczema.
Anti-itching, yeah, I like that. 1% anti-itch. Okay, so you can see here 1%, 0.5, 2%. Okay, so this is considered the least, number 7 here. You can see number 7, and we have number 7 here. So the question here, which of the following topical corticosteroid considered like the least potent? Hydrocortisone 0.1%. Okay. Do you have hydrocortisone somewhere? Yes. If you look on cortisone number 5, class 5, we have hydrocortisone. but we have maybe some chemical structure, butyrate, hydrocortisone butyrate, 0.1 cream. So I'm not going to confuse you here. We need you to remember this one. This one should be remembered. Very important. Betamethasone, dipropionate ointment, clobetasol, the only one. I'm not going to say ointment or cream. We have only one clobetasol, the most super potent. Does that make sense? We need you to remember this one. You can have it when you graduate and work in the clinic. You can print it and put it in front of you. That's fine. But for the practice now, we need to remember what is the super potent. What is that number 7 least? Okay, and then anything in the middle. So, for example, I will go with the betamethasone. I'm not going to confuse you because we have another slide coming here. Okay, we need to look on the student name. The same question, for example, you can remove this one, replace it. You can replace this one, and you can answer which one belong to the class 7, for example, or class 2 or 3. So we need you to remember this one here and remember this one here. And I will bring maybe 3 or 4 between this one here. But it's very important. The first one, last one. Does that make sense? If you like, if you are super maybe hero, you can remember all these categories here. It's totally up to you. But I recommend you to remember all these maybe medication. The first and last one is very important for us. And in the process, I didn't finalize my question yet for the exam, but I'm going to focus on what is the super potent, what is the least potent, and the remaining will be in the middle. So it's not a big issue for us. Okay, so we're done with the cortisone. I need to refresh my mind. I need the help from the student. Can you remind me so you talk about psoriasis, is that correct? Can you remind me with the medication, first medication name, a group of medication?
Topical corticosteroid.
Okay, topical corticosteroid. Okay, number 2.
Salicylic acid.
Salicylic acid. I'm learning from you now. Number 3, I'm taking note. Look at me. I'm writing down. You tell me your information. I'm writing down the information. Good. Okay, topical corticosteroid and salicylic acid. What is the third one?
Coal tar.
Okay, coal tar. Okay, that's fine. Number 4.
Phototherapy.
Phototherapy. Nice. All these considered like topical. Is that correct?
Yes.
Okay, the first 4 maybe medication, topical cortisone, salicylic acid, coal tar, phototherapy. You can type for the group here, topical therapy. Number 5. Denise, okay, we have biological. What else? We have biological agent. And we need more student response to this question. What do we have? Can you remind me? We have biological agent. I typed it there. What else? Methotrexate, good. What else? Lauren, Ore, thank you. Methotrexate, Demard, okay, that's fine. We have another one left, is that correct? Number 7. Okay, acitretin, okay. Moving to the next group of medication, we use it for the psoriasis. We have topical vitamin. We have topical vitamin D analog, and we have calci start with Ca, calcipotriene, calcitriol, and you can see the pharmaceutical name. Here are the images, picture. And this one considered like synthetic vitamin D3 derivative, topical treatment, that's fine. How this medication works, they found this medication inhibit keratinocytes proliferation and differentiation. Okay, this medication may cause itchy skin, dry skin, irritation, erythema, but we need to remember how this medication works. So we have vitamin D derivative used for psoriasis by inhibit keratinocytes proliferation and differentiation. It's important. Number one, we need to remember this medication. When you have calcipotriene, calcitriol, it's like vitamin D derivative, number one. Number two, how this medication works. Inhibit hyperkeratinocyte or keratinocyte proliferation and differentiation. Okay, so I will add it here. Next, we have vitamin D. We have calcipotriene. Okay, Tazarotene, as you can see here, third generation. First line for black psoriasis, topical. We have Tazarotene here. Okay, we don't have a lot of information for that. You can add, you can read information. Then we have tacrolimus or tacrolimus. So depends. I heard several schools speak about tacrolimus, and other schools say tacrolimus. So totally up to you. You can say it whatever you want. Tacrolimus, broad topic here, topical medication, and they found off-label use for severe black type psoriasis. So for black psoriasis, we have Tazarotene approved for treatment. Off-label use, we have the tacrolimus or tacrolimus. Okay. So two medication here, we can add it, tacrolimus, then we have tacrolimus. And we have Tazarotene. Okay. Isotretinoin, you can see it here, available as a capsule. I believe this is the second medication belong to the retinoid oral. Give me the first medication, oral retinoid. You know, retinoids, a group of medication. We have two medication oral. This is the second one. This is medication number 2. What is the first medication? Belong to the retinoid. Type it or say it. Accutane, isotretinoin is correct answer. So the first medication, isotretinoin oral. The second medication, oral, acitretine or acitretin. Acitretin, we have it like second generation, as you can see here, and use it for psoriasis, pustular psoriasis. Here, when the patient uses this medication, we recommend the patient to stop using alcohol. Contraindication to use this medication. Why? You need to answer me if you have any idea or figure out and put it in the chat box when you have time. If you take a break, I'll come back. I'm not sure if we need a break. Okay, is this medication oral? Do we prescribe it during pregnancy? They said no. Teratogenic? No, it's not allowed to prescribe during pregnancy. All vitamin A derivative. Retinoid is not allowed to prescribe during pregnancy. So as you can see, we have two types of vitamin today. We discussed it for acne and psoriasis. We have vitamin A derivative. We have vitamin D derivative. Do you agree with this one? So vitamin D derivative, so for psoriasis, I will go back to remind you. We have vitamin D, as you can see on the slide here, for psoriasis, calcipotriene. So the question in the exam, what is the following medication derived from vitamin and used to treat psoriasis? I'm going to bring a list of medication. So we need you to link the medication to is this medication derived from vitamin? What is the name of this medication? Calcipotriene, vitamin D, all retinoid from vitamin A. Any question about that? Okay. Moving to the next medication. The next medication will be Apremilast. And I've seen the TV commercial about this medication several times, and the brand name Otezla. And you can see it here, Otezla. And the reason here for Otezla, I like Otezla Okay, what happened? Apremilast. You remember AS, as, Apremilast, we have as. And with the psoriasis, we have as. Okay, then how this medication work? This medication used from moderate to severe. You can see it as a tablet here. You can, again, tablet, oral. Okay, how this medication work? This medication inhibit phosphodiesterase. We have as here. You see the AS here in all these medication, Apremilast, psoriasis, and then inhibit phosphodiesterase 4. So if you are in the exam and we have this name, and look where when we have AS, and this is the correct answer. If you don't know anything about the medication, but I believe you know everything now, or most of the information at least. So Apremilast, moderate to severe, mechanism of action inhibit phosphodiesterase 4, and they found this enzyme involved in inflammation. You can read this information: nausea, vomiting, headache, and depression. Some image here how the medication work. You can see the Apremilast here inhibit phosphodiesterase 4. Okay. Any question about Apremilast or Otezla? How this medication work, used for moderate to severe, Apremilast, Otezla. Biological factors. You can see most of the biological factor injectable, very expensive medication, use it for moderate to severe. Okay, drug targets here. We need you to remember these drug targets. For example, which one inhibit or block TNF-α? Okay, so we have it here. Which one inhibit interleukin 12, 23, sterila. Then we have interleukin 23. We have Cosentyx, we have Tremfya, Skyrizi, a long name, and Rosinicimab. It's like long name. We need to remember that one. Okay. So this one important for us, 17A, interleukin 17, secukinumab, this medication here. And I'm looking at the medication Cosentyx. So we need to remember this medication. All these medication important on the list. Do you think Humira, one of the most important medication in the practice? The name is very popular. Okay, so biological agent could be used for moderate to severe. Okay, again, in order to save our time, I already stated at the beginning, I have all these pictures coming from the Google. Now we have question, and we have okay, most of the students agree with the C. I will go back a little bit. So what do you think? Which one? Okay, inhibit interleukin 23. Atopic dermatitis, key concept, we have inflammation, we have itchy skin. Some patients suffer from combination cases called triad, atopic triad. And this could be, you can see like children suffer from asthma, allergic rhinitis, and atopic dermatitis. And you can see the triad here. So the patient may come to some patient may come suffer from atopic dermatitis, asthma, and allergic rhinitis. We call this one atopic triad. Genetic factors, environmental factors play important role, mainly affect the infant, young children. Here, the situation, the patient may suffer from secondary bacterial infections are common in the atopic dermatitis due to the itchy situation, the inflammation, all these components. Okay, how to manage, how to approach the patient. As you can see, I'm focusing on the treatment and management of dermatitis or like eczema. We can go the non-pharmacological approach, avoiding triggers, for example, anything trigger the situation, allergens, chemicals, temperature, humidity. We need to read all this information. It's your responsibility to understand this one here. This is a non-pharmacological approach. What happens if we have any triggers? We need to ask the patient to avoid these triggers. Okay, what is the drug of choice? First drug of choice for the atopic dermatitis, topical corticosteroid. This reminds us with the psoriasis. Psoriasis, first drug of choice, topical corticosteroids. Number one. This is number one. Okay, alternative treatment. Number one, alternative. Okay, still number one, alternative. If, for example, corticosteroid, alternative treatment, you can see here, topical calcineurin. Topical calcineurin inhibitor. Okay, we have tacrolimus and Pimecrolimus. Okay, alternative treatment, not second. So use the topical, then we have calcineurin inhibitor. And number second, so the second line treatment here, we have biological agent, we have JAK inhibitor. So we have three approach now. Number one, cortisone drug of choice. Alternative to number one, we have calcineurin inhibitor topical. Second approach will be phototherapy or biological agent JAK or JAK inhibitor. So we have three options for the second one. Okay, so this one is important for us. So 1, 2, 3. Three approach, three option to treat atopic dermatitis. Okay, non-pharmacological approach. Okay, apply moisturizers, lukewarm bath, lubricant, moisturizer. Here we have some cleanser, wet wrap. We have all these information like a general education to your patient before you start treatment. If we need any maybe approach before the treatment here, and you normally prescribe the patient with a printed leaflet about the atopic dermatitis. Non-pharmacological approach. Identify and remove irritant and allergens. That's very important one. Okay, topical cortisone. This one, for example, if you remember, we have the category for the cortisone from class 1 to class 7. And we discussed about super potent to the least potent with you. Here it's like, make it easy for us. We have low potency, medium potency, high potency, ultra potency, the same. We have less potent, so that what we have here. So when you have patients from atopic dermatitis, how we can approach the situation? They said if the dermatitis on the face, go with the hydrocortisone. And you remember least potent, we apply it to the face. Low potency agent, hydrocortisone. Low potency agent, hydrocortisone, we use it for the long-term therapy because it's safe. So two things. Low potency face, long-term, we go with the low potency. Medium potency, here we go the betamethasone valerate. And someone maybe type here cream could be, if you apply it to the body. Okay, high potency corticosteroid, we can use it for short-term. High potency, if the patients are from exacerbation, severe cases, and we stop the medication. We don't use it for long-term. For long-term, we use something like low potency. But for the high potency, we use it only for short-term. Okay, what about the last one? The ultra-high potency, such as clobetasone and betamethasone dipropionate. They said we can use it, yes, but for short-term only. Okay, short-term, like 1 to 2 weeks. We don't recommend to use it more than that. Here we have some advice, and you can type it here. Avoid potent fluorinated cortisone to the face, genitalial, and the skin, maybe with the folding skin under the breast or under the armpit or somewhere else. So remember this category here, what type of cortisone we apply to the face, what type of cortisone we applied for long-term duration. This is a question. You can create this question, ask yourself, ask your classmate about that. Which medication we use it for exacerbation for short term? Which medication we use it for like severe lichenified lesions on adults? So we have similar approach. This is important things here because face is very important part of the body, and we can see a lot of people come in, especially small children coming with the atopic dermatitis on the face. Okay, topical cortisone, local adverse effect. If you apply it for long term, you can see here stretch mark. Did you hear about that today? Okay, give me medication could be used to treat stretch marks. We have it in our lecture. Retinoids, Zahir, thank you. Kuina, agree. Nathan, cortisone. Okay, so cortisone and Nathan cause stretch mark. Okay, so isotretinoin or tretinoin or adapalene could be used for treatment of. Here they said local cortisone cause stretch mark and skin atrophy. You see this keyword here? Important word for us. And we have list of the medication. You can read it: allergic rhinitis, hypertrichosis. What that mean? Can you someone explain what that mean for us? Focal hypertrichosis. What is hypertrichosis?
Excessive hair growing.
Excessive hair growth. Yes, abnormal hair growth on the body. So you can see here cortisone increase body hair. You agree with this one? Cortisone increase body hair. Okay. The potential side effect here, if you prescribe systemic, okay, if you prescribe cortisone systemic, this is overlap question. What that mean? This one is like covered already in our lecture about corticosteroid. We covered that corticosteroid, and we have it now here in atopic dermatitis. If you prescribe systemic cortisone to the patient, oral, for example, the patient may suffer from suppression of hypothalamus pituitary adrenal. Do you agree with this one? What we call this one here, we call this one negative feedback. Is that correct?
Yes.
Okay, please remember the long-term use of systemic, more than 3 weeks, high doses, we call negative feedback, suppress the hypothalamus pituitary adrenal gland. So anything we emphasize in our lecture, that means it's a question. Does that make sense? So when you take notes, you'll answer the question. So you place, for example, a case study, severe cases of psoriasis, you place the patient on oral cortisone. What is the complication or major side effect? Please remember suppression of this axis here. Okay. Now we start talking about some other medication, calcineurin inhibitor. Calcineurin inhibitor, we covered this one in immunopharmacology, calcineurin inhibitor. But here we spoke about topical treatment. Because if you go to the immunotherapy, immunopharmacology, we cover cyclosporine. Okay, we cover cyclosporine with the oral. But here we don't have cyclosporine. We have tacrolimus, we have Pimecrolimus, and we have the brand name Elidel here. We have Protopic here for the Pimecrolimus and for the tacrolimus. Immunomodulator medication, reduce severity symptoms of atopic dermatitis in adult and children. How this medication work? When you inhibit calcineurin, the result will be inhibit activation of T cells, mast cells. And this will block cytokine mediators. If I am trying to study this one, I'm stuck with the information here. I will type the following for my study to understand the material. I will type here, for example, I use my iPad, my laptop as iPad. I'm going to type here note. I'm pretend like student here. Okay, I will close my camera because I would like to take notes here. So I'm going to type here, for example, tacrolimus or tacrolimus bind to the calcineurin, inhibit calcineurin. Okay, this will lead to the inhibit T cells and inhibit mast cells. Okay, so what do you think with this abbreviation here? Do you agree with this abbreviation here? Tacrolimus bind to the calcineurin, inhibit calcineurin. This will lead to the inhibition of T cells, mast cells, and reduce the inflammation and inhibit inflammatory effect. This is very important issue for the how to maybe understand the situation, because I'm a little bit confused. And from the title, calcineurin, and in the middle we talk about inhibit T cells, mast cells, but we know that this is consequences response, not only one response. By inhibiting calcineurin, this will lead to blah blah blah, blah at the end. The only things here, they said this medication, we have black box warning here. If you click on this medication, some study maybe suggested increased risk of cancer, but here we need to look on the percentage. What is the percentage with the ointment or the cream or something like that? So keep it in your mind, but it's not our keyword for us, for example, here. Crisaborole, and the brand name Eucresa. Eucresa is like crisaborole. We have it here. How this medication work? Inhibit phosphodiesterase 4. Okay, the question for everyone, type on the chat box. This will give you maybe time to review. Give me another medication in our lecture also inhibit phosphodiesterase 4. We discuss this medication with you. This is the second medication. What is the first medication? Work on the inhibition phosphodiesterase. Okay. What is the? What else? Give me the generic name. Apremilast. Apremilast. If you remember, we have AS with Apremilast. You remember that? We discussed AS to remember. Apremilast. And we have phosphodiesterase. We have, thank you. So remember, we have A's with the Apremilast. Okay, so this is the second medication. We need you to remember Eucresa ointment, phosphodiesterase inhibitors, inhibit phosphodiesterase enzyme, topical ointment. You can see the dose there. Patient may suffer from hypersensitivity, and this could be used for children as young as 3 months. Now you have approach. Is that correct? So if the patient comes to the clinic like 6 months old, I will go with the Eucresa. If the patient like 3 years, okay, I can use both Eucresa or what else? Tacrolimus. Tacrolimus, is that correct? Do you agree with this one? I will go back a little bit. We have tacrolimus there. So we have 2 options there. What about the patients like, okay, 6 months, 2 years, 3 years, so and so on. So we need to remember the age when you treat the patient, which one is applicable. Okay, Dapsone. Have you heard about this medication on the TV, for example, Dapsone, Dapilumab? I have one student. Yes, Lauren, thank you, Quina. So Dapsone, you can see that it's injectable. And this medication for atopic dermatitis, expensive medication. How this medication work? And Dapilumab, monoclonal antibodies. You can see it here, monoclonal antibodies. So the question, with the following monoclonal antibodies used to treat atopic dermatitis? We have Dapilumab, Dapsone. Okay, how this medication work? Block interleukin 4 and 13. Decrease inflammation. Subcutaneous injection. Okay, subcutaneous injection. What else? Can we look on the highlight here? We prescribe for patient above or equal 12 years. Now we have 3 months, we have 2 years, and we have 12 years. We need you to put the name of medication here. Does that make sense? Which one for 3 months? Which one for 2 years? Which one for 12 years? Any question about the Dapsone? Monoclonal antibody, inhibit interleukin 4 and 13, subcutaneous injection, prescribed for atopic dermatitis for patient maybe 12 years and above. It's not first-line treatment. Please remember, first-line treatment will be topical cortisone or corticosteroids. Any question about this slide here? Dapsone, Dapilumab. I believe this one last medication for the atopic dermatitis. We have 2 medication here. We have Rinvoq and we have Cibinqo. This medication belongs to the JAK inhibitor, oral genus kinase. What I like about this medication tablet, or like you see here, tablet. So no need for injection. even the price is expensive medication, but if the insurance cover, the patient will be fine. This medication very expensive without insurance. This medication costs $5,000 per 1 month treatment. Every maybe 30 tablets here, around $5,000. With the maybe the insurance could be $50 to $25 per month. So it's very expensive medication. Okay, how this medication work? First, I would like to speak about generic name. We have upadacitinib, and we have abrocitinib. Citinib here, the most of the medication belong to the oral anti-cancer. Abrocitinib, upadacitinib. First of all, we need to remember how this medication works. Inhibit enzyme called JAK inhibitors. So you need to be familiar with this abbreviation, JAK inhibitor, Janus kinase inhibitor. Number one. Number two, can we use this medication? The answer, yes, if the patients are from refractory atopic dermatitis. What is the meaning of refractory, please? Can someone explain to me? Refractory atopic, no break. What else? If the patients are from refractory disease, can I, maybe I'm going to explain it in my way, and you correct me if I'm wrong. Refractory mean the disease not responds to the conventional treatment. We tried to everything and the patient didn't respond. What do you think? Do you agree with this one? So please remember, refractory mean not response to the other treatment. We try everything and the patient does not respond. This is a key word for this treatment here. So Rinvoq and Cibinqo is not the first choice. So we use all the medication, previous medication, no response, not enough response. Okay, so this is the last option for us, not the first option. Okay, so for refractory atopic dermatitis, not adequately controlled with other medication. Does that make sense for us? So this is a key word for this medication, for maybe the question also. 12 years old. So we have repeated information for 12 years old. Okay, upadacitinib, abrocitinib. Okay, this one takeaway point for you. Okay, when I ask about takeaway point, maybe I use this word, this maybe sentence a lot with the clinical research. When the student come to the podium and present their poster with a lot of information, when they finish, I'd ask the student, can you please give us the takeaway point from your poster? So this is a takeaway point from the Rinvoq and Cibinqo. So they said, black box warning here, this medication may increase risk of serious infection, mortality in general, malignancy, cancer, and may increase risk of cardiovascular disease and thrombosis. All these on the table. So we need to maybe keep an eye on the patient, because there is risk of infection, risk of cancer, risk of cardiovascular thrombosis. Okay. Any question about Rinvoq and Cibinqo? So please remember, the same apply for both medication, 12 years and older. Thank you.